colleagues, ladies and gentlemen, welcome to our third plenary session for this afternoon. I am again Dr. Maria Yvette Barres. My co-chair is Dr. Pamela Ferrer. With the advent of the antimicrobial resistance being a great threat to mankind due to inappropriate antibiotic use, it is imperative that we practice antibiotic stewardship not only in the human beings but also in the animals. This afternoon, our distinguished speaker will talk about antimicrobial stewardship, a global point prevalence survey, and the Philippine data. So may I call Dr. Ferrer to introduce our distinguished guest speaker.
Hello. Good afternoon, everyone. It is my pleasure to introduce our speaker. She is the head of the medical department of the Research Institute of Tropical Medicine and the chair of the Infectious Disease Fellowship of RITM. She is the immediate past president of the Philippine Society for Microbiology and Infectious Diseases. She is the lead coordinator for the Global Point Prevalence Survey here in the Philippines. Let's all give a warm applause to Dr. Marie-Rose de los Reyes.
So, good afternoon. I thank the organizing committee for inviting me to present the results of the point prevalence survey we did in 2017, last year, in 16 tertiary, government, and private hospitals in Visayas and Luzon. So I titled my presentation, Antimicrobial Use Point Prevalence Survey Towards Effective Antimicrobial Stewardship. I have nothing to disclose. Okay. We know that antimicrobial resistance is a serious global threat, and I hope that we are also seriously taking steps to combat antimicrobial resistance in our country. This data is from the Antimicrobial Resistance Surveillance Program of the Philippines, showing that pathogens causing common infections like pneumonia and urinary tract infection are already showing high resistance rates. So if you will see for Klebsiella pneumoniae, which is the most common pathogen isolated in respiratory secretions, their resistance rates have, in most hospitals, are more than 20%. For E. coli, which is the most common cause of urinary tract infection, the resistance rates in most hospitals where these are the sentinel hospitals where they get the specimens are already also increasing. So, and this slide is for the Staphylococcus aureus. You will see in the slide that the rate of MRSA in 2017 was already at 57%. And in the slide below, you will see that MRSA rates have remained high over the past several years. These are just few of the resistant pathogens, and there are a lot more, like Neisseria gonorrhea and multi-drug resistant tuberculosis. So in 2014, President Benigno Aquino signed an executive order creating an interagency committee to combat antimicrobial resistance and to formulate the Philippine Action Plan to combat AMR, which they called a One Health approach. And this was launched in 2015 during the first AMR summit. So there are several strategies in this plan that are aligned with global and regional efforts, actually 7, in 7 different key areas. And here, rational antimicrobial use among humans and animals is one of them. And under that is the Antimicrobial Stewardship Program. So where does PPS come into the picture? PPS should be built in as part of the activity or strategy for Antimicrobial Stewardship Program. So what is PPS, or Point Prevalence Survey? It is an established surveillance method for monitoring antimicrobial prescribing in hospitals and is considered as a powerful tool for the effective implementation of AMS programs. The objectives of the AMS of the PPS are to determine rates of antimicrobial prescribing and other quality indicators among hospitalized patients. And this data we can use to provide feedback and develop targets to improve quality of antimicrobial prescribing, to design hospital interventions to promote prudent antimicrobial use, and through repeated PPS, we will be able to monitor the effectiveness of our intervention. So the Point Prevalence Survey is a one-day cross-sectional survey of inpatient wards in the hospitals using a standardized and validated protocol and forms that were developed by the global PPS. So we participated in the global PPS survey. There were 2 paper forms where we entered our data. These are the ward form, which constitutes the denominator data in our computation of the prevalence rate, and the patient form, which constitutes the denominator data. So this is a remote data entry that were done on the sites in different hospitals by the AMS team or by RITM encoders. And verification, validation, and reporting was done with the help of the global PPS program that is based in the University of Antwerp. So there is a long list of quality indicators that we measure, but just to name a few, these are overall prevalence of antimicrobial use, the antibiotic prescribing for community-acquired and hospital-acquired infections, parenteral administration of antibiotics, number of antibiotic combination therapy, documentation of reasons for antimicrobial prescribing, and antibiotic prescribing for surgical prophylaxis. So these were the results. There were 3,692 patients who were on antibiotics at the time of the survey in these 16 hospitals. 55% were males and 45% were females. In these patients, there were 5,933 antimicrobial prescriptions, and 90% of which were antibacterials for systemic use. So we used the WHO classification, or we call that ATC classification, and these antibacterials for systemic use belong to ATC J01. So the overall antibiotic use prevalence rate for adult patients was 52.2%, and for children and neonates is 53.3%. This means that 1 out of 2 to 3 patients in the hospital are on antibiotic. If If you look at each individual hospital, you will note from this slide that there is a wide variation in terms of antimicrobial prescribing, which range from 35% in one hospital to as high as 93% in another hospital, in other hospital. So, since we were participating in the global PPS, we compared our data with that of the other regions that were also participating in the global PPS. So I said earlier, our overall antimicrobial use prevalence was 57.2%, which is higher than the rest of the countries in our region. We belong to East and Southeast Asia. As you can see here, most of the regions have antimicrobial prevalence rate of between 25 to 40%, except for Africa, which has a prevalence rate of 59.3%. So we are second to Africa in terms of antimicrobial prevalence prescription. This is among adults. So in children, you will also see that our prevalence rate is also second only to Africa. So we can say that the Philippines has a high overall antimicrobial use prevalence rates in both adults and children. So let us look at, we also went to look at in which areas in the hospital are antibiotics most prescribed. And in this slide, you will see that the highest usage of antimicrobial is in the adult intensive care unit at 73.5%, followed by the adult surgical ward at 63.3%, and adult medical ward at 52.4%. So in pediatrics, similarly, the highest utilization of antibiotic is in the pediatric intensive care unit at 80%, followed by the pediatric medical ward at 60%, and pediatric surgical ward at 56%. So what are the antibiotics that are commonly prescribed among adults? So in this slide, you will see that the top 3 antibiotics that are commonly prescribed for adults are cefuroxime in 17%, followed by piperacillin tazobactam in 10.5%, and ceftriaxone in 10.3%. In children, the top antibiotic that is most prescribed is also cefuroxime at 16%, followed by amikacin at 13%, ceftriaxone at 11%, and ampicillin at 9%. So then we look at what is the most common diagnosis where therapeutic antimicrobials have been prescribed. So you will see in this slide that pneumonia is the most common diagnosis where antibiotic has been prescribed in the hospital, both for community-acquired pneumonia and hospital-acquired pneumonia. So it's at 40%. So then we ask, what are the top antibiotics that are being used for the treatment of pneumonia among adults? So you will see in this slide that the top 3 are azithromycin at 20%, piperacillin tazobactam at 19%, and ceftriaxone at 12.4%. But if you look at separately, the community-acquired pneumonia from the hospital-acquired pneumonia, you will see that in community-acquired pneumonia, it's azithromycin, piperacillin, and ceftriaxone. But in hospital-acquired pneumonia, the most common antibiotics are your piperacillin tazobactam in 27% and meropenem in 20%. So in children, again, the most common diagnosis for which therapeutic antimicrobials have been prescribed is pneumonia at 50%. So both also for community-acquired and hospital-acquired pneumonia. In terms of the type of antibiotic or the kind of antibiotic that is being prescribed, the most common are cefuroxime in 15%, amikacin in 14%, and ampicillin in 12.8%. For community-acquired pneumonia, it's cefuroxime, followed by amikacin, followed by ampicillin, and ceftriaxone. But for hospital-acquired pneumonia, it's amikacin, meropenem, and azithromycin, and ceftazidime, no, at 16.7%. So in terms of the type of treatment, majority of the antibiotics are prescribed empirically. So 84%, 16% of antibiotics are prescribed targeted. So when we say targeted, there is culture or laboratory support, no? So for pneumonia still, 75% of all pneumonia cases are given IV therapy, and 49% receive more than one antibiotic. So that's multiple antibiotic diagnosis. So the next slide refers to quality indicators for pneumonia in both adults and children. These quality indicators are important in clinical practice because they allow communication among the clinical teams that are managing the patient. So there should be, in your chart, there should be a stop review date documented. There should be a reason in the notes, and we also looked at guideline compliance. So you will note that for the stop review date documentation, we have the rate is very low. So we have because we don't usually practice, no, putting how many days should our antibiotic be up to. So there is 72.3% for reasons in notes that are indicated, and guideline compliance was 78% in children. In adults, reasons in notes was at 82%, stop review date documentation was at 24%, and guideline compliance was 85%. So we also look at urinary tract infection. So if you recall the earlier slide I showed you, urinary tract infection is not one of the top 5 diagnoses for which antibiotics have been prescribed in the hospitals. But you will also note in my previous slides that E. coli, which is the common cause of urinary tract infection, is already showing high resistance to the cephalosporins. So you will see that the most common antibiotic that is being prescribed for urinary tract infection in adults and children are ceftriaxone in 30% and cefuroxime in 17%. But if we go back to the ARSP data, you will see that E. coli, urinary E. coli, is already 43% resistant to cefuroxime, and 47% resistant to ceftriaxone. So it is important that when you make your recommendation for empiric antibiotic use, you localize your data, you look at the antibiogram of your own hospital. So another important data that we got from the PPS survey was the duration of antibiotic prophylaxis for surgeries. So you will see that 80% of surgical prophylaxis were given for more than 1 day. So it's in red. And when you look at the individual hospitals, no, yung red ay the dominant color in the bar graphs. So majority or all of these hospitals really give surgical prophylaxis for more than 1 day. And as to the choice of surgical prophylaxis, the most common antibiotic that are being used are cefuroxime in 31%, cefazolin in 10%, cefoxitin in 8.3%. So we looked at in which surgical procedures where cefuroxime was commonly prescribed. So you will see the slide that among obstetrician gynecologists, their favorite surgical prophylaxis is cefuroxime, and it's seen in about 40%. And for bone and joint surgeries, prophylaxis, it's about 20%. So, but if you go back to the guidelines and look at the recommendation, you will see that cefuroxime is not even a recommended treatment. So the first line that is being recommended for both OBGYN prophylaxis and bone and joint tissue prophylaxis is cefazolin. Okay. So, can we go back? So, okay, next slide. So you will see here that there is also a wide variation as to the choice of antibiotics for surgical prophylaxis. Next, please. Next, please. Next, please. Okay. So now, how do we apply this data from the point prevalence survey to our hospital antimicrobial stewardship program? So this is just one example that was done in Scotland using their results of their point prevalence survey to for their quality improvement. So they identified two quality indicators where they want to target, and these are on policy compliance and surgical prophylaxis. So during the baseline PPS for compliance policy as to the choice of antibiotic, their mean compliance result was 76%. And they set a target to improve that to 95% or more. For surgical prophylaxis, their target was also set at 95% or more. So that is for the national compliance. And the way they did that was that every month they measure compliance to these indicators, And at the end of the second year, they had another point prevalence survey. So as you can see in this slide, the purple-colored line refers to indication documented, and the black lines, solid lines with circles, refers to policy compliance. The red dots are their targets at 95%. So over the past 2 years, there was more than 90% increase in the indication documented, with an overall mean of 93%. So they're not yet there to, they have not yet reached their target of 95%, but they're going there. And for policy implication documented, their baseline was 76%, and it reached up to 90% with an overall mean of 83%. So in surgical prophylaxis, their overall national mean compliance was 96% for a single dose and 93% for policy compliance. So going back to the question earlier, how do we apply our PPS data to our antimicrobial stewardship program? The PPS data are tangible, evidence-based, that we can use as a feedback to our hospital staff, also for staff education and staff engagement. We can use that data to identify priority targets for our improvement and policy development. And this PPS, when monitored continuously, can drive improvement in quality of antibiotic use in clinical key areas. For our case, there are many quality indicators that we need to improve on. And one low-lying fruit is the surgical prophylaxis. I hope that the 16 hospitals that participated in the 2017 survey have made a policy and have on surgical prophylaxis in their particular hospital and are monitoring that. And we hope to see that in the next PPS, there will already be some improvement, and the only way that we will be able to assess the improvements in our antimicrobial stewardship program is through the repeated PPS. So we have the 2018 PPS now, and unfortunately the data is not complete yet, so I cannot present them in time for this convention. So before I end, I would just like to acknowledge the many different people who were involved in this undertaking. So thank you very much for listening.